Good morning, everyone. My name is Lisa Dolovich. I'm Professor and Dean in the Leslie Dan Faculty of Pharmacy and a member of the Ontario Pharmacy Evidence Network Executive. And I am so pleased to invite you today to participate avidly in this event that the Center for Practice Excellence and Open are co-hosting on rethinking space, the next frontier in pharmacy. And this is just such a timely topic. I was just saying to our panelists, so much has been changing, of course, in our pharmacy and our health sector world. How we use our physical space combined with virtual care is such an interesting way for us to think about the future. And I really think that there's so much opportunity for pharmacy to really rethink how we actually can use the space in the best way possible. So I'm really looking forward to this event, to hearing from our panelists and our presenters, and I'm hoping that people will use the chat window, will participate in the dialogue, and really help us all have a great conversation about this topic. So thank you again. I will turn it over to Annalise, who is going to introduce our first panel and get us started.
That's great. Thank you, Lisa. So as Lisa mentioned, we have a panel to start off the day. So I thought that the best way to kind of start with that would be to have each of the panel members introduce themselves for the first 5 minutes and kind of give us a bit of insight into their professional background, the work that they've undertaken at their pharmacy or pharmacies in developing different space and workflow structures. And then also give us a bit of background onto kind of their pharmacy philosophy, if you will. So we're really excited to have everyone here today. I'm gonna get us started just by introducing James Morrison, who's our first panelist. So James is the Director of Pharmacy Excellence at Whole Health, which is a pharmacy banner with independent locations across Canada. He spent the first decade of his career as a designated manager in community pharmacy, practicing in both Parry Sound and most recently in Burlington. He's served in a variety of pharmacy leadership roles and presently holds an elected position to the Ontario College of Pharmacists Board of Directors. James is passionate about a high standard of pharmacy care and the important role that pharmacies fulfill in their communities. So James, I'll just turn it over to you.
Thank you, Annalise. It's very nice to be here virtually with you all this morning. In terms of my professional background, one thing that is left out is I'm a graduate from University of Toronto, which I'm certainly proud of 10 years ago. So it's been a while since I've graced the halls in any formal way, but it's certainly nice to be back virtually with U of T this morning. So you did mention I work with Whole Health Pharmacy Partners, which is an independent pharmacy banner. We have about 70 stores, mostly in Ontario. We have a handful in Alberta, and I'm currently supporting openings in British Columbia, Saskatchewan, and New Brunswick. So very soon we'll be in most provinces across the country. It's a very exciting time. And what I do in that role is provides a very high-touch service with these pharmacists and pharmacy owners as they're envisioning how their pharmacies will look and what type of services they plan to offer. So that's what I do day to day. So I think I have some interesting feedback I can share with you. I've seen, Whole Health tends to attract a lot of pharmacies with a different type of vision for pharmacy practice. So it's not your standard dispensing type of pharmacist. We do tend to attract folks with unique visions of how their pharmacies should be. And one of the most unique is Seasons Pharmacy and Culinaria, which is in Sudbury, Ontario. That pharmacy is basically, we describe it as 1/3 pharmacy, 1/3 commercial kitchen, and 1/3 grocery. And it's not typical groceries. The owners, Rochelle and Lori at that pharmacy, they're trying to bring people closer to their relationships with food and a more holistic approach to wellness. So they actually host seminars in the pharmacy, in their kitchen, and kind of collaborate with other local farmers and folks producing local food goods. So it's really very interesting way to practice pharmacy and a very different approach. We have a number of specialty compounding pharmacies as well in the banner, and one in particular where that pharmacy, they put compounding at the very front of the pharmacy in the front window. So if you're walking by on the street, you could see the pharmacist or the technician practicing the art of compounding in the forefront. So you could really see that it's a different type of pharmacy, and start to think differently about the services you might receive in that pharmacy. And they also focus a lot on holistic wellness as well, collaborating with, for example, naturopathic doctors in that location. We have another very interesting pharmacy in Ottawa called Hybrid Farm, and that pharmacy is focused around cannabis and how patients can use cannabis for medicinal purposes, and very different from other pharmacies, and that they have multiple consultation rooms so that they can have nurses on site doing cannabis consultations or setting up patients to meet virtually with cannabis prescribers to receive medical authorizations. So another very unique model of pharmacy that's departed from the traditional pharmaceuticals and helping patients access medicinal benefit from cannabis when it's appropriate. Aside from that, I mean, we have all sorts of pharmacies I could point to. We do have a number of pharmacies involved in the appointment-based model. So that's when it's not on-demand ordering, but pharmacists are making appointments with their patients regularly to review the medications, assess compliance, adverse effects. And well, I don't think you really need a lot of physical changes to pharmacy premises to enable that sort of consultation to occur. You do, if you're going to be focused on it, you probably need additional resources, for example, additional private areas like consultation rooms to have those meetings. And now with COVID, relying on virtual means, so that we do have pharmacies that are using virtual care models where they can meet with patients on video or by telephone as well and conduct those assessments, for example, medication reviews or reviewing immunizations, for example. So what I do is I meet with these owners and help them determine what their pharmacy might look like and how can we help them to get there. In terms of philosophy, you know, Whole Health is all about bringing together pharmacists and pharmacy owners that are committed to their communities. So they're really the type of pharmacists that are hubs in their community that are very interactive locally, and also dedicated to the practice of pharmacy. So these are typically top tier pharmacists that are really pharmacist clinicians and focused on what can they get, what can they use their pharmacist license to offer the most benefit for their patients.
Thank you so much, James. That's such a great overview. I'm a little bit familiar with the work that Whole Health does, but it's great to hear from you, so thank you. I will turn it over to Brenda Adams now. So Brenda has been a pharmacist in Thunder Bay since 1986. In 2002, she purchased Janssen's Pharmacy and has since overseen the successful operation of one of the largest locally owned pharmacies in Ontario. Brenda focuses primarily on compounding, including bioidentical hormone replacement therapy, long-term care, and compliance packaging. She's fully renovated 5 different pharmacy locations and built an additional location from the ground up. So thank you, Brenda.
Thank you. Good morning, everyone, and thank you for inviting me to share some of my experience in pharmacy design. In 2002, I had the opportunity to purchase a local independent pharmacy And this allowed me to develop a practice model that promoted total health and wellness. And our pharmacy design reflects this philosophy. Just a bit of history about Janssen's. Our flagship store was our first location on the corner of Bay and Algoma, and there's been a pharmacy on this corner for over 100 years. With our moves and renovations, we've had 6 pharmacy locations in Thunder Bay, plus affiliated clinic buildings, all with their own unique design flair. Our pharmacy's been featured in many publications and received many awards and recognitions over the years, including those for pharmacy design and image. Shortly after taking over Janssen's, we embarked on our first renovation project, and this included a complete rebranding and renovating of our Bay and Algoma location. As we expanded, the key features of this rebranding were applied across all our locations. And even though all of our locations have been designed to complement niche markets, you can still walk into any one of our locations and know it's a Janssen's by its look and colors. We began reaching out to individuals who specialized in different areas. We selected reputable companies and some companies that we had prior relationships with, and selected others that we felt we could develop ongoing relationships with that we still work with today. In fact, one of our stores is being tweaked today as we speak. Our pharmacy philosophy was always based on being different. And we wanted to ensure that our look set us apart from others in the industry. We used natural tones and colors and a lot of wood, staying away from the sterile white environment. And although our look is unique, our difference is really ultimately in our service. We've always tried to be pioneers in the industry, and our service offerings have always been guided by responding to our patient needs. Our pharmacists and really our entire team are very hands-on, and they connect with our patients, and patients fill us in on what challenges they're experiencing in healthcare. Being up in Northwestern Ontario, we're faced with unique challenges of many years ago, an extreme shortage of physicians. So we brought 2 nurse practitioners on staff, but that was before pharmacists could authorize prescriptions. Our local health unit divested itself for the most part of travel and vaccine services. So we took that on. One of our nurse practitioners specializes in that. So with the vast number of services that we offer and unique services, these had to be considered when we were designing our pharmacies. The first step in planning was to plan around our services, of course, and decide how much space we needed would be allocated to each service. So some of them needed specialty segregated areas, as James mentioned. Specialty compounding comes with its own unique needs. We also, because we service long-term care, we have aseptic compounding, and our long-term care and assisted living departments are fully automated, so we had to ensure space was developed around our robotics. We do a large delivery business. We do over 500 deliveries a day out of Janssen's, so we did need a designated fleet of cars and a special delivery department. And one of our pharmacies even has a drive-through, so that came with its own unique challenges. The next thing we did was always, of course, planned around our people. So knowing our staff requirements for each area and knowing how our team works. And we used a lot of staff input because our staff are very, we have long-term staff that know the business and know what they need to do to get the job done. So we worked with our teams for workflow and efficiency. We also used external partners like Caverly Consulting and our automation partners to help with workflow and efficiency. So just to have a fresh set of eyes on our operation. And we always kept in mind aesthetics, because even in the back areas, we wanted everyone to have a nice, pleasant work environment. Our retail space is very minimal. It's not a large part of our business. We carry all the professional products, a lot of professional line health supplements, because we did have a nutritional consultant on staff, as well as a fitness consultant. So products reflect these consulting services. And we were able to use the low profile units and really create a pleasant work and shopping environment. And all of our retail spaces are highlighted with video walls so that we can highlight the services we provide. Just one comment about planning for other. We almost in our last reno forgot to plan for a couple of essential things. You're so busy worrying about the pharmacy and the operation. I wanted to mention, we can't forget storage and staff room, which we made sure was well planned for in our last. This was our first renovation project, which was our Bay in Algoma store, our flagship store. And it is a heritage building. So we really wanted to keep the character of this 100-year-old building. It had tin ceilings that were once white, but we painted them a beautiful silver just to give them pop. Everything we did went on paper before we executed our plans. So not only the design of the pharmacy, but all of the workflow, every single person that was working in an area was planned for in our design plans, so that hopefully there were no surprises. Now, however, as I say that, with this location, we quickly learned to plan for future growth. When I took over Jansen's, we started with 6 staff members and 2 phone lines out of this Bay in Algoma location. And then we grew to, under this one roof, we grew to nearly 100 staff doing thousands of prescriptions a day because of our specialty services with long-term care and assisted living. And between 2002 and 2009, we actually renovated this location 6 times to keep up with growth before we opened our second location in 2010. We also had the challenges of unique shaped workspaces, but these could be optimized with proper planning, and they actually add to the uniqueness of the pharmacy. And we had to consider location. Bay in Algoma is located in a busy downtown area with high foot traffic, whereas one of our locations was located in a medical clinic. So waiting space was important. Now, our latest addition to our pharmacies was probably more common in Southern Ontario, but very unique to the north. It was a new build, and this pharmacy took us, I think, 5 years in the planning from start to finish. We are located where I am today between a long-term care facility and assisted living facility. And we call ourselves the Link because we physically linked these 2 buildings. What we did was create a seniors service model. And because it was the entire operation was based around that, designing space for our auxiliary service was of prime importance in this location. We have a hair salon, coffee shop, hearing clinic, foot care, dental hygiene, dermatology, and we planned extra office space so that we could plan for future growth again. So this was quite a unique operation. And prior to us building this Link, seniors, if they wanted to leave their building, they actually had to go outside. So now we act more like a mall where with even an auxiliary shopping shop where seniors can be more mobile. So that was our goal with this build. Just if I can leave you with one comment on, I'd like to close with an important message I've learned over my years in pharmacy design and building. There's no doubt that our pharmacy profession is rapidly changing, and so is our philosophy on patient-directed care. So pharmacy design is an important part of our future and absolutely is essential to be able to, allowing us to be able to conduct our services.
Thanks so much, Brenda. Thank you for the overview and also all those wonderful kind of floor plan pictures. It's interesting to look kind of from the ground up at that.
Yes.
So I am going to go ahead and introduce our last panelist for today. After he gives kind of a short overview, we'll flip it over into general question and answer with the audience. So if there's any questions that are beginning to emerge in your mind, please feel free to use the chat box. I'll be moderating the session for about half an hour or so after Alan presents with us. So Alan Lowe is the founder and pharmacy lead at BioPro Biologics Pharmacy, a novel pharmacy practice focused on resolving patient medication needs and collaborating with physicians and other health practitioners. He's also a clinical associate professor at the Faculty of Pharmaceutical Science at the University of British Columbia, and he is also the co-founder and executive director of Medicines Access Coalition BC. Alan leverages his many years of experience spanning hospital pharmacy practice, pharmaceutical industry, research, academia, and community pharmacy practice to lead, support, and educate people and practitioners to develop better approaches to healthcare. Alan, I'll let you take it away.
Thanks, Annalise. Good morning. Excuse me. Good morning, everyone. It's a little bit early over here on the West Coast. So BioPro Biologics Pharmacy is located in Vancouver. And, you know, one of the things that we do is we walk the talk. I know that many of us involved in academia are always talking and telling our students what pharmacy should do. And very few of community practice pharmacies tend to do that. So one of the things that kind of gravitated me into this kind of practice was a chance to do it differently, to walk the talk and maybe lead by example. So in this particular pharmacy, we deal with a lot of specialty drugs, but we do deal with all prescription drugs, not just specialty. There's compounding, there's OTC, mobility supports, braces. We also coordinate IV infusions as well. So also registered nurses are on staff also. So we offer a variety of consultation services, but we don't have the usual retail products. So you won't find any chips, pop, or candy, or things like that at this pharmacy. So it's all health oriented. So we are essentially pharmacy consultations and more. We conduct medication consultations, which is essentially we identify and resolve drug-related issues. We have pharmacists caring for patients actually in a co-located clinic. So we are connected to a specialist office, and on a regular basis, our pharmacists are with the physician and nurse in that clinic and spend their day there. We do deprescribing, we actively advertise that. We do drug optimization, skincare consultations, pharmacogenomic consultations, as well as get involved in investigational drug studies. So we actually just closed off a study that was looking at treatment of COVID, actually with hydroxychloroquine. We also have a separated compounding room. So this pharmacy is an independent pharmacy, just it was set up before the standards came in for non-sterile compounding, and we did conform to what was anticipated to be the standards, which meant that you are trying to achieve the higher than expected or higher than what actually got implemented. So we've got a powder containment hood, we've got an EMP, we've got an ointment mill, and also, as mentioned by James, is that, you know, you want to put it out front. So the compounding room on the right there is behind the glass. So as people come in from the clinic side, they can see the pharmacists doing their compounding and showing their expertise. So we do deal with pharmaceuticals, but we also deal with non-drug therapy expertise, so from head to foot. So in this first panel here, there's a number of skincare products. So we will do some anti-aging consults as well as offer canes and braces that you can see a pharmacist down that pathway counseling a patient. We also have the world's first Soleus machine. So at BioPro, we've got the first one in Canada. It was approved by Health Canada in August of 2018, and it's indicated for the treatment and prevention of vitamin D deficiency. So essentially, this is a machine that has a filter that controls the UV rays, and in about 6 minutes of exposure, you get 1 week's worth of vitamin D. So again, this just opens up options for patients to have different treatments. So we have spaces for consultations. We call these our pods, and I worked with an architect very closely to design these. You can control your level of privacy. There are blinds at the top that you can pull down. We also have a semi-private consultation space. You can see where folks can sit down and have a chat at, well, we'll call it at the counter. And behind, tucked in there behind the pods, which you can't see, is a Carrel. So we also have a Carrel set up as well. In these consultation pods, they are fully wired so that we can effectively do consultations and counseling using visuals. So it's connected to the computer. We can pull up images, pull up Google Images as we talk about their condition. And also when I type up my notes, I'll let the patient see what I'm typing. So this gets rid of the issue of you hiding behind your computer, and you get a chance to type while they see exactly what you're saying. And that sometimes prompts some questions and some discussion as well. So it's actually a good thing to kind of do up your documentation with the patient right there. So transforming spaces for more is kind of the theme here. As you look at these pods, they're pretty big. They actually fit 4 people very comfortably. We've got 2 of them. And so it gives us lots of room to have the consultation, but it also takes up lots of room in the pharmacy. So it's a good thing we put these pods on wheels. So we actually can move them around. This was certainly a design spectacular as we worked on it. So the architect thought I was kind of crazy, but this way we have a movable consult room. And why would you want to move it? Well, patient education in the community and in pharmacy is kind of the goal here. And what we're able to do is by moving those pods, we can actually fit up to 40 people. So we've had 35, so we've actually tried it and gotten 35 people into the pharmacy doing education. And we'll do education with patients and allied healthcare providers and physicians in the neighborhood. And we've now got a pretty big mailing list that we circulate. So innovation in the time of COVID has been, I guess, easier for an independent pharmacy than certainly a chain. So we continued to administer vaccines during the pandemic because we deal with the specialty crowd and they tend to be more vulnerable. We've switched over to video and telephone consultations. We actually, I'd like to say one of the first to allocate a pharmacist working from home as an innovation during that time of COVID. We did it essentially the day of or the week of the announcement of the pandemic. We started deliveries province-wide, and deliveries certainly stepped up. And we also developed different ways to support physicians, so finding out what their pain points were. And one of the issues is when physicians work from home, not the easiest for them to get a prescription, a paper prescription or any prescription to a patient. So that becomes challenging, as well as even sending it to a pharmacy from their home because of their fax machine not being recognized and things like that. We also offer a number of educational forums and approaches. So we've got the InfoPro, which is our newsletter. During the pandemic, I've partnered up with Arthritis Society and we've given talks. I've got some videos that we've got from myself and our staff that are on Health Choices First that help to educate patients. And recently last year, I was awarded the Ben Gant Innovative Practice Award by the BC Pharmacy Association. So that entails kind of this new startup. And what I'd like to finish off with is, I guess, encourage everyone to step out of that box. Don't be afraid to try it a little bit differently and essentially lead by example. I know that we've been talking about these things a lot, and venturing out and actually doing it is certainly easier than it sounds. So I'd like to turn that back over to you, Annalise.
Thanks, Alan. Thank you to all 3 of our panelists for giving us such a great overview, and I think lots to get started. Zubin has already put in a question for the panel, so maybe we'll start with that. His question: how adaptable have your physical spaces been during COVID, and what do you anticipate will become semi-permanent changes to physical space and pharmacy design post-COVID? So James, maybe could we start with you and get some of your initial thoughts on that?
Yeah, and that is a great question. Pharmacists would like to know the answer as well. So as I mentioned, I do support a number of pharmacies, and COVID, unfortunately, has dramatically altered the physical premises where we provide care. A lot of our pharmacies had very open pharmacy designs to encourage that interaction with patients and bring the pharmacist closer to patients and make the patients feel very comfortable to interact in that setting. We have a lot of very low counters in pharmacies with very wide open spaces. And when COVID happened, we saw pharmacies having to basically turn the dispensaries into what looks like a fish tank for pharmacists, where the pharmacist is behind glass and you're passing papers through small windows and speaking through plexiglass to your pharmacist. And that has been, I'm sure, distressing to both pharmacists and patients. And I've been in those settings myself trying to talk to someone behind the glass, and it very much is a barrier. And one of our pharmacies specializing in methadone described those challenges to me very personally, how you wouldn't think just putting a sheet of plastic between yourself and another person hinders that relationship, but it very much does. And the question on, is that permanent? I think it is, at least for the immediate next year. I'd like to get to a point where we can take down these barriers that we've put up, but a lot needs to happen before that can happen. So whether it's a vaccine that helps us control COVID in the community to a point where the numbers are insignificant, I'm not really sure of the answer for that one, Annalise.
That's great, thank you. Brenda, could we get your thoughts on the question from Zubin?
Yes, very similar to James. We started out, 3 of our locations, our stores are exactly like yours, James, very open, inviting, close contact with patients. So it was really, we put off putting up plexiglass as long as we could. 3 of our locations had them fairly early in the onset of COVID. Our seniors complex here, with patients, with our seniors population, they really, use us as a lot of their social aspect of their days. So we were the last to put up plexi. We ended up putting it back because mask wearing now is mandatory in the District of Thunder Bay. So what we did was we kept open spaces where we could put a mask on to interact with our patients, so we could still give them that feeling of one-on-one. And like you said, James, for the foreseeable future, I think this is just going to be a way of life. And unfortunately, we've kept it aesthetically pleasing as we could, and keeping the space as open as we could. So that's what we've done.
Thanks. And Alan, I guess perspectives from the West Coast on this in Vancouver.
I think we're on the same situation. We certainly have to have the physical distancing, and we have to have barriers up. So yes, plexiglass is up. I don't anticipate that it will be permanent, but certainly foreseeable future. Because we do have some pods that are mobile, we can adapt and do some shifting around. The hardest part actually has been the vaccinations. So with vaccinations, with observation and having a private setting and all the rest of it, it's certainly been effective that we've been able to still use the pods. We continue to do the vaccinations when many of the pharmacies, I think, stopped for a while in kind of March, April, and May. So we ended up having to deal with a PPE shortage. I've paid up to $9 for an N95 mask for my staff, and every patient that we inject, if they don't have a mask, are given a surgical mask to wear during the injection. So it certainly has changed a lot of things for sure. Those kinds of things, I think, may become more permanent than we think. So this, maintaining some sort of PPE as you're having close contact is something that might continue on, I think.
Thank you. We just got another question in from Ernie. His question is, how would you balance designing a solution that meets your customers' needs while controlling costs? This is, I think, an eternal question in pharmacy practice. Alan, do you want to start us off?
So that's certainly always a challenge. And, I'm kind of new in this space in retail. I've been a hospital pharmacist, worked in industry, been in a teaching role in my entire career. And trying to design something and as well as be cost conscious is very difficult. But my, I guess, approach to it was to be as versatile as possible. And that way you don't have to hopefully renovate, 5 or 6 times. You certainly want to avoid that. Those are very expensive things to do, particularly in pharmacies. So my suggestion would be is to think of ways to maintain versatility, how to, I guess, change traffic flow if you need to, Your private consultation spaces, you need to also make versatile because they end up being permanent or quite permanent when you build them. So that was the reason of moving into these pods where I've actually got a movable, relocatable room. And if I didn't need the room, I could actually disassemble it and I guess put it into storage for a while. But it does give as much versatility as possible to reduce not only renovation time, but you know, when you renovate, it's downtime. You're not practicing, you're not seeing your patients, you're needing to kind of essentially close down when you're a smaller independent like ours. But I'd advocate for versatility and think ahead. James, what about you?
Yeah, that's a very good question. And for those probably most interested or pharmacy owners or folks that own pharmacies or have control over the premises, what we do is we try and get multiple quotes for the same project and look at different levels of materials. So if you're looking at a very customized pharmacy build, there's different levels of materials you can get, from more economical up to very high-end materials. So I would do a lot of business planning and budgeting with you to look at, you know, how much can you afford to spend on your build? And you can build a pharmacy, a reasonable pharmacy, for less than $200,000, or you could spend up to $400,000 or more. So it really involves budgeting and seeing what initial spend you want to invest in your renovation or your build, and getting multiple quotes and looking at various contractors as well, different types of materials, to see how you can pull off your vision without breaking your bank book.
Brenda, anything you'd like to add to that is also owning several pharmacy locations?
Just to add on to what Alan and James said, exactly what they said, especially what Alan said, was versatility. That is one thing. We've worked with a contractor, from one specific contractor from day one. So, and because we have many locations, he's able to, if we overbuy some material, we always know we can use it again. All of our shelving units were built in 2-foot pods, so that, you know, we'd have our cash unit, our narcotic storage unit. So if something did need to change with workflow, then they were easily pulled out and adapted to meet the changing needs. And as far as budget goes, again, some things, like with like you, Alan, with your and James, with some of the specialty compounding areas, you know, equipment is expensive, so that has to be, with the changing NAPRA standards. Some of the equipment that we have to have now has to be taken into account, and those are some of the things that we actually can't control with budget. So if we can control our build with our cabinets and units, and have things mobile and versatile, it really helps us change as our practice setting changes.
To follow up on one thing Brenda mentioned there, something I see happening with a lot of greenfield, what we call greenfield or brand new pharmacy builds, is that they will reserve a room where they're going to do the specialty compounding. It's kind of their dream that they're going to do it, but they won't invest in all of that equipment at the very beginning until they have the cash flow to support it and the patient volume. So there's different ways to do it. You don't have to build the whole pharmacy all at once. You can kind of do a phased approach where you do your core dispensing first and then build out those facilities you need for more specialized services. That's another way to look at it.
Thank you, everyone. The next question we have is kind of going back to the current situation with COVID, from Doris. Her question is, communication has been challenged with the safety measures associated with COVID-19, as we've been discussing. What design have you experienced that would be most effective for communicating with individuals who either cannot read or who may be hard of hearing? Really interesting question, especially with everyone wearing masks.
Yes, well, during COVID, I think it does get difficult. However, if you are quite adept with dealing with video chatting, video conferencing, certainly it is a very visual way to do it. There's not a lot of reading because you're doing a lot of speaking. We've actually ordered in and have had before that a lot of the demonstrators of everything you can demonstrate. So every device, inhaler, injector, you name it, that kind of stuff, to make sure you're prepared to be able to do the video counseling as well as showing people over video. Sometimes you need to have them call in by phone because the video is also a bit challenging, but what you do is you try to make the video part of it really easy. I think the audio is more of a challenge because a lot of times you'll connect that video, and it's probably happened here with many of you, where the video is working, but the sound doesn't work. So you connect up by sound just to take one piece out of it. And if you know how to, I guess, and get really quick with sharing the screen, that becomes really useful because then you can pop up stuff. And if we ever go back to a non-COVID approach, these video screens inside our consultation pods have been really helpful. They're on an arm. We can swing them out so we can face it towards the patient and their caregiver. And this way it allows them to see what you see on your computer. So we connect up our computer to it. And again, this is back, once we're through the COVID type issues. I imagine that we might have to stand up a piece of plexiglass between the patient and us, but regardless, they'll have the screen right in front of them and that kind of thing. So just as some suggestions.
Yeah, I'll just add one more comment. Whole Health does a lot of patient-focused programs, and with that, we always produce infographics for patients that are educational but are very low in text and contain a lot of visual representation, so images that help to educate them on whatever the condition may be or the pharmacy service, so that it does help with people who maybe have trouble with literacy or reading or even hard of hearing, because they can see these images and help and understand the materials a bit more. We also produce materials in multiple languages. So for example, our flu program posters, they are in, I think, about 20 languages now available to our pharmacies, depending on your demographics of your patients. So we try and provide resources to help pharmacists have effective communications and promote services in different ways.
Just to add briefly to what James had said, our business has always been very involved in home visits with our patients. So both our nurse practitioners and our pharmacists spend a lot of time. We have 5 full-time consultant pharmacists on staff that just don't spend any time in the dispensaries, but spend time out at our long-term care facilities and our assisted living facilities and in mental health counseling. So with this, we try to use caregivers with any of these patients with special challenges as much as we can as well. But it certainly has provided a challenge since we are so out and mobile with the restrictions of going into individuals' homes at this time.
Mm-hmm. Great, thank you everyone. Still have a couple questions from the audience to get through, which is great. This one from Nancy: have any of you considered starting a community pharmacy residency? And do you take pharmacy students currently? Your creativity, patient-centered approach, and innovative approaches would be great to seed by involving students as they are learning.
So I'll start. We certainly do take students, and we take them 2 at a time, even though it's one location. We currently have 2 students on this week who are wrapping up their practicum. We'll start another 2 next week. I've taken community pharmacy residents on different roles that I've been in for the last 20 plus years. So I've always been working with community pharmacy residents. And funny, Nancy, you should ask, but I've actually approached a couple of groups in BC hoping that they would be interested in partnering or working with me to start a community pharmacy residency. In fact, I'd be the coordinator. I'd actually help to lead it, but I do need some other supports in place. And I have approached 2 groups because we've recently had our coordinator retire. So that's Penny Miller, who's run it for, again, probably 20 plus years. And it's certainly something that's needed. So that training, I think, is imperative. We may have to adjust it a bit now with our entry to practice PharmD graduates. And one of the things that we don't see happening a lot in community pharmacy is physical assessment. We're teaching our entry to practice PharmDs to do it. I've been trained with a postgraduate PharmD, so I am also trained in physical assessment. And, I would use it rarely for therapeutic drug monitoring. However, in practicums and in practice, maybe in hospital, some of our students might see it. But in community practice, again, this leading by example and showing students is going to be very challenging, since many of our practitioners who are currently practicing aren't going to be using physical assessment. So I've got 2 stethoscopes in the pharmacy that are ready to be used. We've got a number of other monitoring devices, encouraging the staff to use their skills. However, it's going to be a challenge for pharmacy because it's very new to us. And we don't have a lot of preceptors who are trained in regularly using physical assessment skills. So I'd love to see a community pharmacy residency program, maybe that's national, at least provincial. And so anyone on the call who might be interested, I'm game. Give me a holler.
That's great. Brenda, do one of your pharmacy sites currently take pharmacy students? Or?
Always. I've had, for pretty much all my years in practice, I've always had a student, and like you, Alan, sometimes more than one. We're lucky to have locations that can take multiple students at a time, both pharmacy students and pharmacy technician students. And we really think it's important because it gives, I've got a whole rotation, student rotation that plans for the student to at least be exposed to every aspect of practice, because I always like to tell them that it's something that you know, going into certain types of retail practice, you may never be exposed to, but at least if you've had the exposure to aseptic compounding, specialty, long-term care, nurse practitioner services, travel medicine, we really like to share all our different areas of expertise with these young and upcoming pharmacists. So it's something I've always done.
That's fantastic.
Here, Annalise, here at Whole Health, we love having students. We have, in the peak of, well, through the pandemic, I think we've had about 5 or 6 placements from both U of T and also co-op students from Waterloo. And we really rely on these bright young minds to help us develop programs that are more forward-thinking and cutting edge, and really challenging us to think about things differently with new perspectives. So I very much love the influence we have. Nancy, we actually were interviewing for the next co-op term. We interviewed 5 Waterloo students just this week, and I'm really looking forward to having one of them join us next year, or next co-op term. And in terms of formalizing relationships with our stores, if that's something I can help with, or Tiana here in our office, getting some of your students into our more innovative type of pharmacies, we have lots to choose from. I'd certainly be happy to help build out that network to get even more students at Whole Health Pharmacies.
Oh, that's great. And Nancy says, thank you for supporting our students, and obviously really likes the idea of a national pharmacy residency program. So that's fantastic. Just want to go back, a question from Drew Petty. Most of you have mentioned a move to virtual care. How have you dealt with the technical issues, such as poor internet connections in rural areas, or sometimes in urban areas as well? And the tech knowledge gap that sometimes exists with your more senior patients. And I think that this is particularly important when we're talking about some of the audio connection and video connection for vulnerable patients or older patients. James, do you want to start us off with that? I know I've worked with Whole Health a little bit on this, so.
Yeah, and thank you, Annalise, for your help on that. I know I'm a little bit removed from all of the ABM study, which is happening, but I do understand a lot of what's going on in our stores. And, you know, for virtual care to happen, you don't always need the internet. We found with certain patient populations that the cumbersome technology aspect with virtual care, having to get on the internet or even on a video for some patients, is challenging. And even some patients prefer not to go on the internet for a video conference. So we found a lot of these remote, or what you would call virtual services, such as appointment-based model, could happen over a traditional landline or cell phone. So there are ways to provide care remotely without, having folks on video like we're doing right now. So I would say be flexible and work with the patient on which tool they'd be most comfortable with and use it. So give options.
Great. That theme of versatility is definitely coming up over and over again. Alan, do you want to weigh in on any thoughts?
Sure. Certainly, I'll encourage having options is very important. It's too bad that these video connection links, not all of them have end-to-end encryption. So you have to be very careful in what you choose. And I think in the first session that you guys had on this with virtual care, that was a discussion that came up. And, a lot of pharmacies, I don't think, realize that. They were using all sorts of video platforms which really aren't properly approved. And so you don't have that versatility of offering patients different modalities, but I think over time we will be able to do that. So catering it to the patient is very important. See what modality they're comfortable with and have used before. I think it will fix itself over time, and that I think many folks will find a way in how they communicate given this COVID situation. And if you find out from them what they've been using, what they're most comfortable with, go with that. Forcing a new modality onto somebody certainly doesn't work. Everyone is comfortable with phone. Have not found any senior or patient that's not comfortable with phone. Many of them still have landlines. So, that's your first thing. And you can slowly transition them over. You can have them walk them through their video link and all the rest of it. But I'll also suggest another thing. On our website, we have several educational videos. So there's a whole library of them that are available throughout the internet. One of the areas that I like to use is called Health Choices First. I've been involved in creating some of them. And the thing is, they're 2-minute videos targeted at very specific things. So if you wanted to counsel somebody on inhaler use, well, there's a video on that. And it's one that is non-branded, non-partisan, that kind of thing. And you can send them a link. So most are quite comfortable with receiving a link by email and then playing those. So that's another way that you can send education that's almost foolproof. And you're not going to have too many technical glitches doing it that way. But certainly we're still growing and dealing with some of these virtual communication issues that we're going to continue to have. But keep that phone line handy. We installed another phone line in the pharmacy because we just needed it. It's a lot of phone conversations now.
Mm-hmm. Those resources online sound great, Alan. If you wouldn't mind maybe popping your website into the group chat, and then I'm sure there's lots of people on the call who'd be interested in opening it up and taking a look at that kind of content.
I will do.
Brenda, any last thoughts on kind of the transition more to virtual care?
Well, up here in the north, we're still using the good old telephone. So that is our primary method of speaking to our patients at this time. We have used with our facility partners, though, because we do service not only Thunder Bay, but we service Northwestern Ontario for long-term care and assisted living. So we have, in the past, we have used the Ontario Telehealth Network. So we have that set up in 2 of our locations that our professionals are able to liaison and join in care conferences with patients and families that way.
Great. And I can see Alan's just put in the website into the Zoom group chat if anyone wants to take a look. So I know we are kind of at the end of our time for the panel discussion. I just kind of want to tie in the last 2 questions that we had online, and then just maybe in a minute get a summary from each of you, kind of on pharmacy moving forward and the integration of how pharmacy fits into the broader healthcare ecosystem, the linkages between pharmacy, patients, and other healthcare providers. So maybe if each of you could give us a minute kind of wrap up on that would be great. James, can I turn to you to start us off?
Yeah, well, thanks, Annalise. So, and thank you for having us. What I'm seeing in my pharmacies is a lot of collaborative practice with the local other healthcare providers, not necessarily physicians. And in some cases, we actually have pharmacies including those folks on premises. So building out a pharmacy that has a clinic with many treatment rooms and also subletting to other sorts of alternative care providers, whether it's physiotherapy, even dermatology clinics. And we pretty much have every sort of model you could imagine in the banner. So just working with folks in your community, and they don't even have to be on site. We have pharmacies, for example, that have gotten very much involved in fertility when they identified that local need in their community to have a pharmacy that could provide high-level care in that area. So just look at the other clinicians in your community and just see how you can work together to optimize the patient outcomes.
Thank you so much for that. Brenda, last thoughts?
Yes, it's something we've been doing for years. As I mentioned, almost 20 years ago now, we had brought our first nurse practitioner on staff and now have 2 full-time on staff. So it really helps with our clinical services. It helps us reach out to the community. We have an amazing relationship with our district health unit that we're able to collaborate with all sorts of other professionals. We do service and specialize in mental health and group homes. So we work closely with mental health institutions. And it really is, I could not envision our practice without collaboration with these individuals. We servicing long-term care. Our day-to-day activity is speaking to physicians and nurses. So this has been a long time part of our practice, and I encourage everyone to get out there and like James said, they don't have to be physically present, but these relationships are just essential to be able to provide optimal health outcomes these days, and they can really make a difference.
That's great. Thank you so much. And Alan, to wrap us up.
Thanks. Well, I think with the collection of people that we have here, I'd like to, I guess, suggest and encourage everyone to see how they can promote the pharmacy profession. Right now, I think the problems that we have is the expectations by patients and practitioners, and I'm talking about the other healthcare practitioners that we deal with. They don't really get what pharmacy can do. They understand the dispensing side. And although we have a lot of doom and gloom that we talk about dispensing, we're still going to need pharmacists for dispensing. Whether Amazon comes in and takes us over or not, we'll still need a few of those pharmacists to deal with the dispensing, probably a lot fewer. And we'll have to, be cognizant of that fact, but to encourage both the profession as well as patients to really perceive pharmacists differently. What I think is holding us back, and I'll have to give a few disclosures here because I do coordinate our pharmacy management and leadership course at UBC. I've also got a textbook out there called Pharmacy Management in Canada that I'm co-founder and co-editor, which I make nothing from. So that plug is doesn't get me anything, but it helps fundraising for the Foundation for Pharmacy, or CFP. But it is those management leadership skills that I think we don't instill in our new graduates and students so that they are able to help move the profession forward, those advocacy ways and that kind of thing. I know many of the folks that are online are preceptors and do deal with students, and that's something that we don't show them a lot of. We may be showing them a lot of clinical training, but clinical training on its own doesn't get you anywhere. If the patients or if the system or the reimbursement isn't there for us to exercise our clinical skills, it's not going anywhere. So we do need both together. And right now, we probably need stronger on the administrative, business management and leadership role, more so than clinical. We're graduating entry to practice PharmBs, clinically very well trained. I do hope that they can use their skills to help patients, but we have some challenges in front of us. And I think we can overcome them if we kind of work together and push this. And, certainly COVID has allowed us to accelerate some of the things that we do. We've got some prescribing, some openings, some policy changes that have really pushed pharmacy to the forefront. And I know with the upcoming flu season, we're going to be utilized a lot more. Let's leverage that to really showcase pharmacy and what we can do to help patients.
Thank you. Thank you, Alan. Thank you, Brenda, and thank you, James. I think I'm probably speaking on behalf of everyone who's online listening. Great session. Thank you for all your responses to the questions. Really grateful as well to have as much audience engagement as we did. So the next, we're going to take a short break just for a few minutes. We're at 11 right now, so I think maybe take let's say a 3-minute break. People can grab another coffee, head to the bathroom quickly, and then we will restart at 11:05. We have 2 presentations, 2 abstract research presentations for you, followed by a bit more question and answer with the audience online. And then we'll wrap up for the day. So Brenda, James, and Alan, if you're able to stay for the rest of the session, that's great. Otherwise, a very sincere thank you from all of us at the Center for Practice Excellence and also Open.
Thank you. Thank you for the invitation to speak with you.
Thanks, everyone. So we'll regroup in about 3 minutes. So hi again, everyone. I think we're going to go ahead and get started with the second half of our session today, which are some research abstract presentations from two people. So I'm going to pass it over to Nancy Waite, who is going to introduce our first presenter for the day. Nancy.
Great, thanks very much, Annalise. And just thank you to the panel. I have to say, when I look at our co-op jobs, and I'm sure I see Karen cameras on as well, she looks at some of the rotation options. I think sometimes I'm just going to go back and actually apply for those jobs because there's so much exciting stuff that's going on out there. And just hearing from the panel just reminds me that it's really an exciting time to be out there and exciting to see what they're doing. So really pleased to introduce our speakers for this afternoon. We're not quite there for the second part of our presentations today. And our first presenter is Michael Cardinal. Michael's recognized as a pharmacist committed to improving the care provided to the population and the renewal of practices in healthcare. He's been awarded prizes and distinctions from the Canadian Pharmacists Association and the Faculty of Pharmacy of the University of Montreal. Through his research, Michael is trying to validate the relevance and impact of using digital health tools in pharmacy practice. He's the Chief Clinical Officer at Therapix, and you're going to tell me if I pronounce that correctly, Michael. Good? All right. A company that contributes to patient-centric preventive medicine by properly curating and enabling digital health tools through powerful technology and relevant services. Welcome, Michael, and thank you very much for your presentation today. Annalise, are you going to share the slides? And I can't give you the title because I don't have it quite in front of me, but we will have, oh, Michael's going to be doing
That's okay, yeah.
Perfect.
Yeah.
So he'll be speaking today on digital health tools in pharmacy and experimental studies. So thanks very much, Michael.
Thank you, Nancy. It's very appreciated, and thank you to the Leslie Dan faculty and Alice for putting this event up. And a lot of buzzword in that introduction, but I'll try to make it clear and see how we can do research around it. So first things first, I'm Michael Cardinal, a PharmD that's graduated from the University of Montreal. I am a community pharmacist and also, as I mentioned, the Chief Clinical Officer at Therapix. So we're a company that is curating digital health tools and as mentioned, I'm going to present today a project that is funded by MedTech and University of Laval, the AgeWell group, and the Canadian Foundation for Pharmacy. So I see that Dale is here today. Hi, Dale. And of course, our company. So it's a collaborative research project, meaning that we work in a consortium way, and the project is held at University of Laval totally independently. But I'm going to be today presenting the project for our researchers on their behalf. So basically, the principal investigator is Lynn Gannett at University of Laval, the Faculty of Pharmacy. We also have the chance and the honor to have Kelly Grindrod in our collaborators. She's been involved in validating digital health tools since I probably wasn't even a pharmacy student. With Sophie Lausier, also an associate professor at Laval University, and Lucie Blais, a full professor at University of Montreal. And a master's that we're looking for at the University of Laval. I'm doing a little awareness on this because we're still searching for this person. So if there's someone in the audience that wants to pursue a master's in epidemiology and wants to evaluate digital health tools, it's your chance. And we also have private collaborators. So me, myself, and Alex, our CEO, and Dale from the Foundation for Pharmacy. So the research is the development and validation of a technique used by community pharmacists to identify and recommend digital health tools to assist patients to effectively manage their chronic disease. Before that, I just want to make sure we're on the same page. We have a lot of definition around digital health and health. These definitions are very broad and very too extensive. There's now a new definition in the industry, which is digital health tools. So the new term for health. This refers to all the apps, mobile web-based apps, or the new category of digital therapeutics, which is really more labeled than anything else. It's a new industry that's forming in the landscape to make sure that we can separate health and wellness versus like complete modalities that are evidence-based and that can actually treat patient by itself, being a software and patient-facing, so on a mobile health phone, for example. And these categories are all in digital health tools. So this is the tool, the term that I'm going to use. So I'm going to say DHT today, just to make sure I don't, say it too much. The context, we have 87% of Canadians who use a smartphone. A lot of physicians and pharmacists are asked questions on digital health tools. As a young pharmacist, I'm often asked around, medication adherence tracker tools. And there's a lot of Canadians that use actually more than probably you thought. 32% of Canadians use a smartphone app for their health. This is stats from 2017, so we expect it to be way higher. Of course, with the pandemic, with the new unmet needs and the way the healthcare system is reshaped, health apps play a larger role now than ever before. We have seen a lot of more adoption rates in terms of mobile apps with clients that we have at Therapix. The only thing is, and also, sorry, in terms of context, we have, pharmacists that play a larger role as we transition from a role from distribution to primary care and now to chronic care management. Of course, most provinces now can, adjust doses of medication for diabetes, hypertension, and other chronic care diseases. So it leads to, further needs in terms of how we can operate these services. Now we can make sure they're streamlined, and digital health tools might have a role to play in that. So as I mentioned, potential digital health tools are really an adjunct to therapies. So we call that RX Plus, in the fact that, and this is already demonstrated in a lot of studies. So this is not the objective of our trial, but it's really to add that to see how we can streamline the integration of digital health tools. But, as a state of the art, of course, companion apps are seen as a way to improve the outcomes and bring value in the way we interact with our patients. And there's also a standalone, there are also standalone tools, which I don't feel like are going to be the ones that are going to be the most successful in pharmacy. So they're not the ones we target in that research. We target about tools that help a pharmacist and a patient have a relationship in regards to their health. Problem is, there's a lot of apps out there. So we believe in 2018 that there were 170,000 apps. That's a lot of potential missed opportunities, but if properly assessed for their value. Health Canada won't regulate 99% of these tools because they're judged as low risks, but there are still risks for patients, like privacy, like security, like clinical value. And it's a mess, basically. So it's a minefield, as I say, going in the App Store and seeking for an app, because you don't get advice on proper use of these apps, and you don't get advice, of course, on the value of these apps. So we feel like healthcare providers have a role to play in that, and that it may, bring a more patient-centric relationship, as long as there's a personalization. So it's very important to make sure that this care experience is successful, that patients are supported in their selection of digital health tools, and that's what we want to validate in pharmacy, basically. So the purpose is around a platform, a hub that we refer to as software pharmacy, in which there's going to be an interaction between the pharmacist and the patient in the selection of digital health tools. So what we want to validate through that research project is the components of a software pharmacy that will generate the outcomes on engagement. So better engagement to apps, of course, increases the outcomes. So we want to see if the engagement is improved with such a platform. And we want to know if targeting a specific digital health tool for a patient as a pharmacist brings value to the patient, or rather that the patient should choose and pick the digital health tools on its own. So there's a lot of, questions around how we can operate the recommendations of apps. And this is what we'll try to specify, validate. And of course, if it leads to outcomes. So we don't assume that, health apps for medication adherence in this case will increase medication adherence. We want to validate it during the research project. Just to make sure you have more understanding on the context, how it's done, it's first with the standardized assessment. I've mentioned that Therapix is a company involved in that. So we will validate and improve our assessment framework through that research, which is basically done by 2 steps, a robot and researcher assessment that will look into the apps and identify things such as privacy issues, security issues, usability assessments, health conditions and functionality, also regulation. So if it's regulated by a regulatory agency in this case. And then there's going to be a clinician assessment if there's no-go criteria. So if the apps are judged low risk and feasible, there's going to be a clinician assessment with our panel, so our expert panel, which is composed of 28 multidisciplinary primary care professionals, and most of them are pharmacists. And then there's an app library in which the healthcare provider will be able to see and access information on the assessments on each digital health tool. So this serves on 2 use cases. One, if the patient asks a question on a specific tool, or second, if the pharmacist wants to pick his own tools that he can use with his patients. And then patient-centric recommendations. So we want to evaluate, as I mentioned, if the prescription of an app should be done by the pharmacist or the patient, and see how they can interact with each other. So we have designed a formulary in which there's going to be a match, so an app matching based on the patient's availability of a smartphone, pricing, so feasibility criteria and acceptability criteria, and then some criteria such as the level of intervention that we want to target. Do we want to provide just information on, medication adherence to a patient, or rather something that's more, comprehensive, such as, behavioral change or objectives. And based on these objectives that the patients and the pharmacist have in regards to the care, the care experience, we're going to be able to match the tool based on the clinician assessment that we've done earlier. The work plan that we're looking at is step 1, the assessment. We have a target of 200 apps. We're on 50 as of now. The project has just started at the beginning of September. The step 2 will be qualitative assessments on the software pharmacy. So basically focus groups, semi-structured interviews with patients. We want to make sure to have a patient experience that's really patient-centric. So we have patients and pharmacists as part of the research phase 2. There's going to be, after that, an experimental phase in pharmacy. I'll move on to the targets after that. And after the experimental phase, we're going to do some data analysis to, of course, measure the outcomes and inform also our AI algorithm to make sure that we can identify which tools are more successful for which kind of patients based on the data that we'll be able to gather. So it's a triple arm study, quite a lot of a big objective. So our study objective is to have 4 to 6 pharmacies, mostly in Quebec, 8 to 12 pharmacists, 300 patients during a 6 months follow-up period. There's going to be 3 arms. So the arm 1 is the sole intervention of pharmacists, so the usual care, which will be advised on, a complete, discussion with their patients on medication adherence. The second will be an intervention plus the patient will be recommended a list of apps, but not curated. So 20 or plus apps to see if the patient can choose it by its own. And third, an intervention plus the prescription of a patient-centric tool based on the assessment that was done by the pharmacist and the patients. Measured outcomes will be on primary on patient engagement and patient-reported experience measures. So net promoter scores, care experience, if the patient has perceived an added value in that care experience. And the secondary outcome is the most important one, but secondary because we're not sure if we're going to be able to have statistical power on that, but it's the objective measurement of medication adherence, so pre-post intervention. It's going to be using the platform Remed, which, if you're not aware of, is a platform that can be used in research to measure pre-post interventions in terms of medication adherence, mostly in Quebec because they're integrated with RAMQ claims. And that's it. So basically, I made it short to make sure that we can, have a complete overview and discussions around this. So I'll be very willing to answer all your questions.
Thank you very much, Michael. That was very interesting. And certainly we're all inundated by all of the apps for so many applications, but you can imagine what a patient is facing. And we've had a number of interesting things even just presented to me in the last week. And so this is great to see. We're actually doing some research on this, so thank you. We are going to hold our questions to the end because we want to have a lot of time for the questions. And so you'll see in the I just indicated, if you have questions for Michael, please put them in now so that you don't forget them. And please indicate P1. And then as we do our second presentation, just indicate P2, and we'll know that that question is directed to those speakers. So thank you very much. I have so many questions. I'm going to hold so that we can move to the next presentation, and really appreciate the time you've taken.
Thank you.
So our next research presentation we're going to fit 3 people into our 15-minute time frame. So thank you for being so engaged to have 3 speakers. Our first speaker will be Ross Yuki, who is a professor and chair at the Department of Pharmacology at the Faculty of Medicine and Dentistry at the University of Alberta. Oops, sorry, I just lost my, there we go. Carleen Luskin has been a pharmacist for over 25 years and is a consultant in the field of pharmacy continuing education and pharmacy practice change. And Randy So is a master's graduate student in the Department of Pharmacology at the Faculty of Medicine and Dentistry at the University of Alberta. Welcome all, and thank you very much. They're going to be talking today about the impact of a pharmacist first innovative workflow plan in patients with hypertension and or diabetes. So welcome, thank you.
Great, well, thanks very much. And good morning, everybody from Alberta. It's great to be here, and thank you so much for choosing our abstract. So we're going to do this as a team of 3. I'm going to just give you the introduction. Randy, can you go to the next slide, please? All right, so as all of you know, there's super strong evidence for the care of patients by pharmacists practicing at their full scope, particularly in the area of cardiovascular diseases. The problem is it seems to stop after the trial is done. And even in the sites that are participating in the studies, they tend to go back to what they were doing before. So where this really falls down is implementation. We need a model to implement the evidence that we have. And so, as you know, usual community pharmacy workflow where patients, they might see a pharmacist at the end of the dispensing process is really not, it's reactive, and it's not conducive to what we need to do is proactive patient care. So a few years ago, I met Carleen Luskin, who's going to speak next, and she's developed an innovative approach, which we're calling Pharmacist First. And she's going to speak to exactly what that looks like. And we've got a short video to show you as well. But essentially it focuses on assessment of the patient by the pharmacist at the very beginning of the encounter, which allows things to be much more proactive. So I'm going to turn it over to Carleen, and she's going to explain this to you, how it works in her pharmacy.
Hi there. Are we going to play the video then, Ross, or are we going to keep going on the slides?
Keep going on the slides. The video is embedded in right after this.
Okay, yeah, so this is just a quick overview of what the design of the pharmacy looks like, just so you can have an idea of the schematics. And then just giving the next slide, Randy, it'll show the what it actually looks like when it's built out. So we designed the pharmacy particularly to ensure that patients were approached first by the pharmacist, so that care happened upfront. Which again, as Ross said, allowed us to be very proactive in the care of the patient, allowed us to solve drug-related problems, which is really upfront, which is really the most efficient way in pharmacy practice to do this. Randy, just advance there. So again, this is what it really looks like when it's not, empty, and just shows those are actually 3 pharmacists up at the intake station there, and allows us to see the patient up front, but also allows us to pull up care plans right away. Working with them on their chronic disease states, and also we do a lot of phone follow-up, so you can see, one of us at least is on the phone there.
And can I just also add that you see the technicians in the background, they're in the center of the pharmacy, and I'm not sure if you can see off to the right, but there are private examination rooms as well. Sorry, go ahead.
Yeah, go ahead and advance, Randy. So yeah, we'll just play a little video here, and I'll just walk you through sort of what a typical encounter looks like. This would be a repeat prescription with a patient. And really, in most cases, when patients come in with repeat prescriptions for chronic meds that they've been on for a long time and nothing changes, they really don't even see a pharmacist. It goes in, nothing's changed, it goes out. But this is a way that that we approach that, and it's very different. So go ahead and play the video, and I'll just walk you guys through that. So the patient approaches. with a prescription. And so the pharmacist can have a look at it right away. And this is, the patient is usually fresh out of the doctor's office, or at least in the prescription or her medications and therapy is right in the forefront of her mind. So we like to talk to them right away. So we're going to pull up the patient's care plan, take a look at the prescription, see that nothing has changed, and you can see the support staff in the back there. I would have talked to the patients, realized that, prescription has no drug therapy problems, same as before, but I pass it back to give to my support staff to fill. So that allows me to spend that time with the patient. So I'm actually going to take her blood pressure, which we do regularly with our hypertension patients, just to get, a regular recording of where they're at with their drug therapy, to assess the appropriateness of it, and to continue to monitor, and also to educate them. So allowing the support staff, the technicians, to work to their full scope allows the pharmacist to then work to our full scope. And we talk about it all the time, but again, as Ross said, it's often not implemented in pharmacy practice. So while we're doing a blood pressure with the patient, I'm also pulling up her care plan. So the care plan is an ongoing therapeutic relationship or documentation with that patient. So I can see back years with this patient as to what we've been working on. And it allows for continuity and for me to start off today with the patient where we left off last time. That might be with goals a patient might have as far as her exercise or nutrition goals. Could be clinical goals that we have, that if her hypertension was not quite controlled, have we done anything to advance that? There could be all kinds of things that we're working on, but it allows me to see what the pharmacist did with her last time, so that we're not starting from scratch every single time with that patient. We're not saying, what does this patient know about her hypertension? Well, we already know that. Where is she at? What's her last reading, so we can compare it to today's reading. So all those things get done up front with the patient, and then the patient goes, and you can see the pharmacist doesn't actually leave that station. The assistant and then the pharmacy technician finishes off the prescription and then dispenses it out to the patient. So it's really a separation of the technical check and the clinical check. And sometimes it makes pharmacists nervous because they're like, well, wait a second, who checked that script? Well, I signed off on it as a pharmacist as the clinical check, and then it went back to the dispensary staff, and the technician signed it off as the technical check. So it's a real separation between the clinical and the technical check, which is what allows us to free up that time for the patient. Thanks, Randy. You can just advance to the next slide.
So I guess I will start. We evaluated part of this. So we evaluated part of this workflow model in 2 community pharmacies in the greater Edmonton region. And then our study was to evaluate the effects of the impact of this model on blood pressure and glycemic control in patients with hypertension and/or diabetes. So we conducted a retrospective chart review, and we examined patients with hypertension or diabetes, and examining our primary outcome was the change in blood pressure and or A1C from baseline to their last follow-up visit at each pharmacy. So of the patient charts we examined, we saw that 51% of the patient population was male, and we had an average age of 69 years old. 58% of our examined patients had hypertension only, as well as 37% having both hypertension and diabetes. And we saw our smallest population in the diabetes only patients, consisting of only 6%. So the dotted green line is just patients with diabetes. The gray line is patients without diabetes, and then the blue line is the overall total, combining both populations together. And we can see a significant reduction in both systolic and diastolic reduction. We see a reduction of 8.5 millimeters of mercury in systolic, and a reduction of 4 millimeters of mercury in diastolic blood pressure. So from our study, we found that this pharmacist first workflow model showed significant improvements in blood pressure, but we do acknowledge that though this is a retrospective chart review, we do not have a true control group, which is a limitation. But nonetheless, we feel that there is sufficient promise to evaluate this further in a prospective study.
Great. Well, thanks very much. And we're happy to take any questions.
Thank you very much for being so timely as well. I really appreciate both presentations, and excellent, really interesting to see how, you know, this is actually playing out in real practice. And so thank you. And it's great to see we're actually measuring some outcomes in that space as well. So at this point, I'll turn it over to Annalise, who's going to manage the questions for both of our speakers. And again, thank you.
Perfect. Thank you, Nancy. And thank you to our presenters. Really nice contrast from our panel this morning. So first question is from Zubin. He's directing this to Ross, Carleen, and Randy. His question is, which came first, the physical design of the pharmacy, which drove the practice model, or your practice model, which required you to modify your space accordingly? And then he also asks, how did you refine your practice model without having this kind of space in the first place?
Sounds like a Carleen question. You're muted, Carleen.
Oh yeah, okay, yeah, I can answer that. Good question, Zubin. Yeah, so I've been practicing pharmacy for 25 years, so of course I didn't always practice this way. And I opened my own space here 8 years ago. So prior to that, I had of course been thinking about the pharmacist first model and how it could happen, but wasn't really allowed to practice that way in the place that I was. And so yes, when I designed the space and opened, it actually opened at half this size. I only had one intake station, but it was a pharmacist first intake station. And then a year later, we expanded it to the model that we have now with the 3. So I guess the space came first, but really the continued sort of efficiency and development of the workflow and the type of patient care has developed over time, because I really didn't have any role models in it to follow. I was kind of like, I knew what I wanted to do, but I wasn't really sure. And then I had to develop the team who was also going to, you know, do this with me. And of course I started out really small with just me and an assistant, and we've expanded then to a team of about 10. So it's kind of developed over time, and the whole separation of a clinical check versus a technical check was something that we also developed over time as we had more support staff. So I guess it's sort of, you know, both, in that I knew what I wanted to do, so I developed the space, but it wasn't completely, you know, 100% conceptualized in my mind as to how we were going to do it until we started doing it. And then we kept refining it as, you know, as I went along. I kept looking at it for more efficiencies and better patient care. And then the care planning process came along when we could develop the software to allow us to do that right on our pharmacy software as opposed to paper. So things have kind of developed over time. So I hope that answers your question.
Yeah, I think that's great. Just as a follow-up to that, I was wondering if you could maybe give us kind of 1 or 2 of your top lessons learned. Like, I think with a lot of more agile methodology and tweaking things over time, both in a patient-centered care perspective and then also with your research, maybe like the top 2 things that major things that you learned and tweaked along the way.
First thing is, you need to have a very strong team leader, or the team is going to always go back to the way it always has been. Like I said, I've been practicing for 25 years, nothing really changed. And if it wasn't for the fact that I kept bringing my team back into it, and every time I bring a new member into the team, it's a culture that has been now set up that has to be, you know, this is the way that we do things. And I think it's a real cultural issue in pharmacy practice right now, is that things don't change and our new grads come in and adapt to the current culture because there isn't really strong leadership. And there isn't really even sometimes a conceptualization that there needs to be a team leader in the dispensary, but there has to be a vision, and you have to keep going back to it to say, why are we doing this? Well, we're doing it because this is what we think is the most important for patient care. This is the best way to look after patients. So you need to have some strong leadership there.
Mm-hmm. Great, thank you. Have a few more questions rolling in. So this one's for you, Michael, if that's okay. Nancy asks, are you looking at any of the SMS intervention programs? Since they don't require downloading an app, they're a bit simpler for direct interactions and intervention with patients.
Yeah, of course. So in our category of digital tools, we include all software or service that can be included as part of the patient journey. So either web, SMS, or you know, on a mobile perspective. Our assessments was designed for really web and software that's on the web and app perspective, but other digital tools are included also in our study. So it could be interesting if you have one in mind that maybe we didn't catch. Of course, there's a lot to add the information on the tool, maybe the specific tool you're looking at. We could include it in our research, of course.
Great. All right, Michael, I'm going to keep you in the hot seat now. From Ernie, he asked, what was your inclusion or exclusion criteria for A, digital health tools, and B, patients?
Okay, so the first part of our assessment comes with a pre-selection. So we have a robot that crawls all the apps that are available on App Store and